General Surgeon Teresa's.
General Surgeon Teresa's.
General Surgeon Teresa's.
Hello, welcome to the ASGBI Moynihan Academy Surgeon Teresa's podcast. My name is Jared Wohlgemut, an SD5 in general surgery in West of Scotland and research lead for the ASGBI Moynihan Academy. My fellow interviewer is Max Marsden, ST8 in general surgery in the London Deanery and trauma lead for the ASGBI Moynihan Academy. And we're excited to have Professor Jansen joining us for the podcast today. Dr. Jansen is the lead author of the UK REBOA trial study and professor of surgery at the Heersing School of Medicine, Department of Surgery in University of Alabama at Birmingham, USA. He's also Associate Vice Chair for Clinical Trials, Director of Research for the Division of Trauma and Acute Care Surgery, and Director of UAB Centre for Injury Science. Welcome, Professor Jansen.
Thank you very much.
Thanks very much, Jared. So really excited to be here today and have Professor Jansen with us. We're going to talk about the UK REBOA trial. It was published in JAMA in October of this year and has had already in excess of 30,000 views, has an altrometric score of over 500. And it is arguably one of the most anticipated and hotly debated papers in trauma surgery at the moment. The abstract states that the purpose was to determine the effectiveness of REBOA when used in the emergency department, along with standard care, and compare that against standard care alone on mortality in trauma patients with exsanguinating hemorrhage. It was a pragmatic, Bayesian, randomized clinical trial conducted at 16 major trauma centres in the UK, and the primary outcome was all-cause mortality at 90 days. Along with several important secondary outcomes.
That's great. Thanks, Max. So this is a very unique trial. And I think a lot of our listeners, most of which are general surgical registrars, but also other allied healthcare professionals and other doctors around the UK and internationally, will want to know how these methods were unique and why did you choose them?
Yeah, thank you very much. And to be honest, I don't think they were that unique, really. But I think you're probably referring to the use of a Bayesian design here or a Bayesian analytical framework. That was fairly novel when we started designing the study, which was 10 years ago in 2013. But I think it's actually become a lot more mainstream since then. And that is in no small part due to COVID, which resulted in a few trials that use Bayesian analyses. I think it's probably fair to say that many people are still less familiar with this type of statistical analysis than they are with the more commonly used frequentist analyses. But that's really all it is. It's just a different way of looking at it, different way of doing it, and it actually offers many advantages compared to the frequentist framework that we're more used to.
I've heard people say, the reason Bayesian study was done is because we just want to recruit less patients. Is that a fair description of why a Bayesian approach is useful, or is it more complex than that?
It's more complex than that, and there's no inherent advantage in terms of sample size when you use a Bayesian approach. But what matters is that you end up with results that are much more interpretable than a frequentist analysis. And perhaps the best example of that is this output called the posterior probability. So the posterior probability is an actual probability of an event happening or not happening, and is therefore very different from a p-value. P-values are difficult at the best of times. Well, Max, I'm sure you can define what a p-value represents, couldn't you?
Oh, I wish you hadn't.
That's not good. Yeah, that's fine. But, sorry, but it proves my point. A p-value is actually a really difficult concept for most people to grasp. And it also, of course, results in this dichotomization of results into 95%, 5%, whichever way you look at it. The output of a Bayesian trial is much more helpful because it is this actual probability of an event taking place or not taking place, and that's a continuous outcome. So therefore, the results are much more interpretable and actually much more interpretable for normal clinicians without a background in statistics.
Awesome. Okay, let's dive into the results a bit.
The trial enrolled 90 patients, and of these, 46 were allocated to the standard care plus REBOA group and 43 to the standard care group. One patient declined to continue to participate after 4 days. And what we found was that with regards to the primary outcome, 90-day mortality, 25 of the 46 patients in the standard care plus REBOA group, that's 54%, had died, and 18 of the 43 in the standard care group, so that's 42%. So yes, that is the wrong way around, so to speak. So mortality was considerably higher in the standard care plus REBOA group, the intervention group, compared with the standard care group. And to put the numbers on it, that translates into an odds ratio of 1.58 with a 95% credible interval of 0.72 to 3.52. Again, because this is Bayesian, the usual thing about crosses one, therefore not significant, doesn't really apply. And furthermore, the posterior probability that I talked about earlier of an odds ratio of greater than 1, which means REBOA is harmful, was 86.9%. So a pretty high probability that REBOA is associated with harm, and in particular with excess mortality. And that's clearly not what we had hoped to show with this trial. We did this trial because we thought that REBOA might be helpful in reducing mortality in trauma patients. But this is exactly why we do clinical trials. We need to properly evaluate new interventions in this setting and in a randomized study so that we know exactly what they do.
There was some crossover from one arm to the other. So 19 out of the 46 randomized to REBOA actually had a balloon inflated. And of the 27 who did not, 17 improved with standard resuscitation efforts. 8 were unsuccessful attempts at REBOA. 2 patients deteriorated and the procedure was abandoned. So I'm just wondering, Prof. Jansen, what effect on the outcome did this likely have? And has there been any criticism or questions about whether a per protocol analysis would be useful given the amount of crossover?
So I think the most important thing is that there weren't really crossovers, and we have really tried to avoid this term in this context. So REBOA is what's called a complex intervention, and a complex intervention has a definition. The definition is actually quite useful. It's from the MRC, but essentially an intervention is considered complex either because of the properties of the intervention itself, such as the number of components involved, or the range of behaviors targeted, or the expertise and skills required by those delivering the intervention, or the setting, or the levels targeted. You get the drift, and you can see that REBOA very much fits into that. This was not a trial of drug A versus drug B. It was a trial of 2 strategies, 2 treatment strategies, either standard of care or standard of care plus REBOA. And therefore, clinically, it makes perfect sense that not all patients progress all the way down the REBOA pathway, even that's where they might have started out. And in fact, we identified very clearly that there were 3 common intercurrent events. The first one is that patients got better with other resuscitative measures. We see that all the time in trauma patients. The second one was that patients actually got worse and died before we could even get the REBOA in. And the third one was that it just wasn't possible to place the device. So coming back to my earlier point, these are not really crossovers. They are very real-world important events that need to be taken into consideration when evaluating a treatment strategy that includes REBOA. So that's why we try to avoid that term crossover, because that's not really what it is. However, in answer to your question, no, we did not conduct a per protocol analysis because, frankly, they're terrible. They're really heavily biased, and from a methodological point of view, they're not advisable. But we did conduct additional analyses using what's called a complier average causal effect analysis, which avoids some of the issues with per protocol or traditional per protocol analyses. I'm happy to talk about that, but I think that'll probably take us beyond the end time of this interview. So yeah, please do read the manuscript, which has got more details in it. But in essence, these were additional analyses that showed that the results were essentially the same as those of the main analysis, even when those intercurrent events were taken into consideration.
Thanks, Prof. I think that's really helpful and very enlightening. One of the things that I was fortunate enough to help enroll a couple of patients, and one of the kind of ideas that came to mind when I was reading the manuscript was, what if we'd moved the point of randomization along the pathway a bit, and perhaps only randomized patients when they had, I don't know, vascular access or the catheter in the aorta. But I suspect, listening to your answer to Jared's question there, the response might be that actually we wanted to see the whole REBOA process rather than, cherry picking those cases where REBOA is likely to happen. Is that fair enough?
Yeah, absolutely. So it's important to think about what this study was designed to achieve. And what we were trying to do is, and what we did do is, we conducted a very pragmatic clinical effectiveness trial that was designed to evaluate REBOA at a system level in UK major trauma centers. And remember that this study was funded by the NIHR, and in particular by the Health Technology Assessment Program. And this program is really about policy decisions. It's about changes that are made at NHS level, and to evaluate whether these interventions that are being proposed will make a difference at a system level in NHS hospitals and to NHS patients. So that's what this trial set out to do, to answer that question. And I think that's what we have to remember when we're looking at these results. Yeah, we could have moved that entry point, as you say, to the right a little bit, but then we would actually miss out on a really big part of this, which is getting the arterial access in these patients, which is clearly the Achilles heel of this technology. If we could fix that, life would be a lot easier. But it is very real, and it has to be part of this.
Oh, it's fascinating. So you did say just now that this is funded by the NIHR and the HTA, and it's meant to assess whether or not this would be feasible in the UK as a policy. What about somewhere else? Have you received any criticism, or have you reflected on whether the same thing was implemented in another health system, perhaps in North America, where they see more penetrating injury? Would that have had any change at all?
Yeah, I think we have to recognize that the results of this trial are location specific. They were conducted in the context of UK trauma systems and major trauma centers, and we therefore do have to be careful about extrapolating the results to other settings. I don't think that's really a limitation of this study. It's just a reflection of where the study was performed. Does it mean that different results might be obtained if a similar study was conducted, say, in the United States? Yeah, for sure, it's possible. But until somebody does one, this is the best evidence that we have.
So one of the things we wanted to ask you was, if you were to rerun this trial, whether there was any changes you might have made to how it was conducted, or are you happy that actually you ran the trial that answered the question, and the question is, REBOA causes harm in UK ED practice or English ED practice?
Yeah, I mean, no trial is ever perfect. And I don't think any trialist has ever looked back on their trials and said, yeah, we could not have done that any better, for sure. And I think there's a number of things. I think the first one is more of a comment rather than something that could be improved. But it's interesting that this trial used 90-day mortality as its primary outcome, which is a very downstream outcome to use for a trauma hemorrhage control trial. And you'll both be aware of the discussions that have taken place on the subject over the years. John Holcomb has done a lot of work on that, published a paper, I think it was 2 years ago, on choice of primary outcomes for hemorrhage control trials in trauma patients. And really what the recommendation is now is that we use more proximate mortality outcomes for these trials, like 6-hour mortality, for example. And the reason for that is, of course, that the mortality difference, which is present at that time point, persists as patients progress through the trial and is present even at 30 days or 90 days. But in many trials, the increasing number of deaths for reasons other than hemorrhage, in particular traumatic brain injury, increases in both arms, and it therefore becomes more difficult to demonstrate a difference statistically. The reason why this is important is because in this trial, despite that common limitation of hemorrhage control trials, we still managed to show a really big difference even at 90 days. And I think that shows how important a difference it is and how big this difference is. And you've both read the paper. I mean, we looked at more proximate mortality outcomes as well. And as expected, the posterior probability was even higher at these earlier outcomes. So I think that's just a general thought regarding choice of primary outcome for trauma hemorrhage control trials. I think what I would do differently if I did this again, I would certainly try to incorporate more of a mechanistic component. I think this trial was very much designed as a clinical effectiveness trial. That's reflected in the choice of outcomes and also the data that were recorded for this study. I think looking back now, especially with the results that we got and the increased mortality, I think what we would really want to know is, well, what was the impact of the intervention on patients' physiology? Did blood pressure actually go up when the devices were inserted? And did patients have excess mortality despite the fact that their blood pressure was improved, at least temporarily, by the device? We just don't have that data. The trial wasn't designed that way. It wasn't designed as a mechanistic or as an efficacy trial. It was very much designed as a downstream clinical effectiveness study. But yeah, like I said, with the results that we got in the end, unexpectedly, it would be really nice to have some mechanistic data.
Yeah, I agree. One final question, if I may. You have done a really good job throughout this trial of not just conducting the trial results, but also having other qualitative and mixed method studies running alongside it. Can you talk to any of these as far as, maybe to teach people or to inform people who might be considering trials methodology, that there are other things other than simply the quantitative analyses to be considered?
Yeah, I think there's a whole range of things that can be addressed with qualitative research. And I think qualitative research is still regarded with a degree of suspicion by many clinicians and surgeons in particular, a bit like Bayesian statistics, really. But I think there's a lot to be gained from that. And in particular, in the context of a trial, especially a trial that was as complex and as difficult to run as this trial, is how can we improve things? How can we improve enrollment? How can we improve the delivery of the intervention? And although some of that stuff can be captured quantitatively, and there are undoubtedly useful process measures that can be put in place and reported and can be used to improve the running of the trial. There's also a lot of qualitative stuff that can be done. And yeah, we did that with this study.
Awesome. Well, thank you, Max, for joining, and thank you, Prof. Jansen. It's been really informative, and hopefully for the listeners, you've learned something to go away with and read this UK REBOA trial published in JAMA in 2023.
General Surgeon Teresa's.